Anesthesia.
Anesthesia. Very good. Go ahead.
So firstly, peri-op anticoagulation management is based on why is the patient taking anticoagulation, what type of anticoagulant is the patient taking, and what type of surgery is planned, and how should the anticoagulant be managed perioperatively. Does the patient require emergency surgery, or what is the risk of thromboembolism and bleeding?
Very good.
Reasons for patients being on anticoagulant are various common cardiovascular disorders like acute coronary syndrome, stroke, peripheral vascular diseases, atrial fibrillation, venous thromboembolism, prosthetic heart valves, and patient with intravascular stenting. And the type of drugs, heparins, vitamin K antagonist, and direct orally acting anticoagulations. Heparins, which are unfractioned heparin, binds to antithrombin 3, which inactivates factor 10A and 2A, blocking the conversion of fibrinogen to fibrin. Their common uses are prevention and treatment of acute thrombotic events and anticoagulation for dialysis and cardiopulmonary bypass. These drugs need regular monitoring with activated partial thromboplastin time or the activated clotting time. And the dose is 80 units per kg bolus dose followed by 18 units per kg per hour intravenous or subcutaneous. Then the low molecular weight heparins, enoxaparin and dalteparin, they potentiate the action of antithrombin 3 indirectly and irreversibly. They have quick onset of action. Dose is 1 milligram per kg 12th hourly. And fondaparinux, which is also an indirect factor 10A inhibitor, binds reversibly to antithrombin, but its half-life is longer than the heparin. Vitamin K antagonist, also known as coumarins, warfarin, acinocumarol, fenprocumin. These drugs, which inhibits the reduced form of vitamin K, which serves as a cofactor for gamma carboxylation of coagulation factors 2, 7, 9, 10. Because of its indirect mechanism of action, it takes several days to reach onset and offset. Warfarin, which has 100% oral bioavailability, onset is 24 to 72 hours, duration is of 2 to 5 days, and its T-off is up to 36 hours. And the direct acting oral anticoagulants, rivaroxaban, apixaban, endoxaban, and betrixaban, which binds directly to factor 10A without complexing to antithrombin 3. They have shorter half-life and no long-term monitoring of, for these anticoagulants is required. Dabigatran, which is direct inhibitor of factor 2A, which inhibits the formation of fibrin from fibrinogen. Its peak action is within 2 hours and half-life is 14 hours. Then the antiplatelet agents, these are used for the prevention of atheromatous strokes and thrombosis in peripheral vascular diseases, acute coronary syndrome after coronary or endovascular stenting. Aspirin is an irreversible COX-1 and 2 inhibitor, which prevents the formation of prostaglandin A2. Its effect lasts for the lifetime of platelet up to 8 to 9 days. And the other antiplatelets are clopidogrel, ticoplidin, prasugrel, which inhibits P2 white well receptor on the platelets, decrease the stabilization of platelet clot formation. And the other antiplatelets are ticagrelor and congrelor, which are reversible non-competitive platelet P2 white well receptor aggregation inhibitors. Glycoprotein 2B3A inhibitors are apixaban, eptifibatide, and tirofiban. And based on the type of surgery, whether it is a low bleeding risk surgery or intermediate high bleeding risk surgery, we'll manage it perioperatively. For a low bleeding risk surgery, oral anticoagulants should not be interrupted. For intermediate high risk of bleeding surgeries, anticoagulation should be stopped. And at the same time, if the patient is at the high risk of thromboembolism, it should be bridged with low molecular weight heparin procedural. So conditions present a high risk of thromboembolism are patient with mechanical valve prosthesis, mechanical aortic valve prosthesis, or with more than 2 prosthetic cardiac valves. patient with intracardiac thrombus or placement of a coronary stent within last 12 weeks, patient with single non-provoked DVT within the last 6 months, and presence of atrial fibrillation with CHAD-VAS score more than or equal to 5 are associated with rheumatic valvular diseases. These are the patients who are at high risk of thromboembolism and should be bridged peri-procedurally. So perioperative management of anticoagulants according to ASRA guidelines, warfarin should be stopped 5 days prior to high risk and intermediate procedure, and the INR should be normalized less than 1.5. It can be restarted after 6 hours of a procedure, provided that the INR is less than 1.5. Acinocumaril, which should be stopped 3 days before, provided the normal INR less than 1.5 for a high risk and the intermediate procedure, and it should be restarted 24 hours after a procedure. Heparin, if it is used intravascular, it should be stopped 6 hours prior to a high risk or an intermediate risk procedure, and it can be restarted after 2 hours after a procedure. If it is used subcutaneously, then it should be stopped 24 hours prior to a high risk procedure and 6 hours prior to an intermediate procedure, and it can be restarted after 2 hours after a low and 6 to 8 hours after a high risk procedure. Low molecular weight heparins, enoxaparin, if it is given for a prophylactic use, then it should be stopped 12 hours prior to a high risk or intermediate risk procedure, and it should be restarted after 4 hours after a low risk procedure and 12 to 24 hours after a high risk procedure. Dalteparin, it should be stopped 24 hours prior to a high risk, intermediate or a low risk procedure, and it can be restarted after 4 hours of low risk procedure and 12 to 24 hours after a high risk procedure. Then antiplatelets, clopidogrel should be stopped 7 days prior to high risk and can be to 24 hours after a procedure. Prasugrel should be stopped 7 to 10 days before a high and intermediate risk procedure, can be restarted after 24 hours. Ticagrelor should be stopped 5 days prior to a high risk or intermediate procedure and can be restarted after 24 hours. Cangrelor should be stopped 3 hours before a high risk or intermediate procedure, since it is it has a short 4 hours. Dabigatran, it is procedurally based on the creatinine clearance. If the creatinine clearance is more than 50 and the patient has no renal impairment, it should be stopped to the intermediate procedure. If the patient has renal impairment, it should be stopped 5 to 6 days prior to the procedure and can be restarted after 24 hours. Rivaroxaban, apixaban, edoxaban, all these drugs should be stopped 3 days prior to the procedure and can be restarted 24 hours after a procedure. GP2B 3A inhibitors, apiximab, which should be stopped 2 to 5 days prior to the procedure and can be started 8 to 12 hours after a procedure. Eptifibatide and tirofiban should be stopped 8 to 24 hours before a procedure and can be restarted after 8 to 12 hours. Before stopping or starting the anticoagulants, we should consider the risk and the benefit ratio of potential bleeding and potential adverse effect of holding the anticoagulants. And bridging, it is for a patient who are at thrombotic risk. We should discontinue warfarin or clopidogrel 5 days prior to the surgery, and the INR should be maintained less than 1.5 to bridge it with low molecular weight heparin at a therapeutic dose. And this low molecular weight heparin should be discontinued 24 hours prior to the surgery, and the surgery can be proceeded when the INR is less than 1.5. Post-operatively, if the patient is fluids, warfarin can be restarted after 12 to 24 hours, or if the patient is at a lower risk of bleeding, low molecular weight heparin can be restarted after 24 hours. If the patient is at high risk of bleeding, post-operatively, low molecular weight heparin should be restarted after 48 to 72 hours after the surgery. And the low molecular weight heparin should be stopped when the INR is more than 2. Finally, the emergency reversal of anticoagulations. If the patient is on warfarin and coming for a minor procedure where the bleeding is minor and non-urgent, we should stop warfarin and give vitamin K 1 to 10 milligram IV or orally. And if the surgery is emergency and anticipating serious bleeding, we should stop warfarin. We have to give vitamin K 10 mg IV slowly, and we should consider giving prothrombin complex concentrate infusion over 1 hour based on the INR. If the INR is 2 to 4 times the normal, prothrombin complex concentrate should be given 25 international units per kg. If the INR is 4 to 6 times the normal, it should be given 35 international units per kg. If the INR is more than 6, prothrombin complex concentrate should be given 50 units, international units per kg. Alternatively, we should give fresh frozen plasma in a dose of 10 to 20 ml per kg. Then if the patient is on unfractioned heparin coming for an emergency procedure, these effects can be reversed with protamine. 1 milligram of protamine reverses 100 international units of heparin. Alternatively, we can use fresh frozen plasma or prothrombin complex concentrates. If the patient is on low molecular weight heparin, its duration of effect is usually 24 to 48 hours, and the protamine maximum 50 mg can be given, and it is incompletely reverses the effect of low molecular weight heparin. Directly acting oral anticoagulants. Prothrombin complex to reverse this directly orally acting anticoagulants, prothrombin complex concentrate is the first line treatment. Rivaroxaban and apixaban can be reversed with andexanet alpha, which is a recombinant modified human factor 10A decoy protein. Dabigatran can be reversed with monoclonal antibody idarucizumab. That's all, sir.
Good. So all of you know why patients are put on anticoagulation. It may be because of some cardiac surgical, post-surgical conditions like valve replacement or a stent placement. Or patient might have had some neurological problem like a stroke, where you don't want, especially the thrombotic stroke, to happen again. So you anticoagulate those patients. Or patients who are compromised vascular flow to the periphery, where you don't want a thrombus to further deprive the limb of the perfusion, then they are put on long-term anticoagulation. So mostly it is related to the cardiovascular, peripheral vascular, or central nervous system conditions where you don't want a thrombus, or an earlier incidence of pulmonary embolism in a patient, or a DVT. These are also causes where patients are put on anticoagulation. So if these patients happen to have a surgical condition and they require a surgery, then what are the guidelines we should follow? The main problem when a patient who is on anticoagulation comes for surgery is twofold. One, if we cut off or stop the anticoagulation completely, there is a chance that he may develop a thrombus and the existing condition may get worsened because we are mainly giving the anticoagulants to prevent a thrombus formation in the patient. But the other end of the spectrum is patient may develop very severe bleeding intraoperatively depending upon, as she said, the type of or the nature of surgery, whether it's a mild bleeding surgery or a moderate bleeding surgery or a heavy bleeding surgery. So we have to do a balancing act of preventing a thrombus formation, at the same time not losing the patient because of unmanageable intraoperative or postoperative bleeding. So these are the two important aims or goals in our management of patients who are taking anticoagulant drugs. And Vidhya has very nicely and elaborately described all those things. Anyway, as usual, for you to have a visual impression, I'll just share my screen with you. And is it visible? Is the screen visible, Vidhya?
No, sir.
No?
No, sir.
Now?
No, sir.
Are you able to see something now?
No, sir.
No. Now is it visible?
Yes, sir.
Yes, sir.
Okay. So just describe the guidelines for especially regional anesthesia, but it also important for patients who you want to do general anesthesia also, especially patients with coming for cardiovascular indications. If they are on anticoagulation, even your laryngoscopy and or nasal intubation can cause severe bleeding. So forget the word regional anesthesia there. Remember, it is for anesthesia. Guidelines for anesthesia and patient on anticoagulation. So what are the first, you must know what are the indications for anticoagulation therapy. It's most commonly indicated in patients, of course, I forgot to tell about atrial fibrillation, DVT, pulmonary embolism, or placement of prosthetic heart valves, or patients who have undergone percutaneous coronary interventions, especially who are on dual antiplatelet agents after the procedure, or patients with past medical history of stroke or CABG or essential thrombocytosis could require antithrombotic therapy. The second, what are all the drugs used for anticoagulation? Only when we know the pharmacology and the nature of action of the anticoagulant drugs, we will be able to understand and adjust the dosage accordingly. So the commonest drug that is given for many patients is aspirin, acetylsalicylic acid. Second is non-steroidal anti-inflammatory drugs are also used. So what is the difference between aspirin and NSAIDs with regard to anticoagulation effect, Vidhya? This is a common question they may ask you in the examination, especially Viva. Anybody else? Sanjuta? Sobika? Shankari?
Sir, NSAIDs cause a qualitative platelet abnormality also.
That's not the answer. Hiranmayi? See, aspirin, when you
Irreversible inhibition of platelet.
reversible and irreversible. That is the correct answer. The aspirin causes irreversible binding to platelet. That is why when you administer aspirin, it lasts till the lifetime of the platelet. What is the normal lifetime of the platelet?
7 days.
7 days.
5 to 7 days. So till the new platelet is formed, all the existing platelets which have been exposed to aspirin, they will continue to be inhibited by aspirin. Whereas if you give diclofenac or brufen or aceclofenac, all these NSAIDs, once the blood level of the drug gets removed, antiplatelet effect also will go away. So it is a temporary action. Whereas aspirin, once you take 300 milligrams or 150 milligrams, that will suppress the platelet till the lifetime of the platelet. So that is the major difference, reversible and irreversible binding to the platelet. Okay, this is a common question they will ask you in the exam. Please remember that answer. Then thiopyridines, clopidogrel and prasugrel. non-ticagrelor and cangrelor. These are the chemical and pharmacological divisions. And vitamin K antagonist, warfarin, and then direct inhibitor of factor 10A. All these drugs you can identify, but they will have that XA or 10A in their name. So all drugs which are inhibitors of factor 10A, that is activated factor 10, they will all have this XA in their name. Apixaban, endoxaban, vadixaban. So remember that by this identification of the XA in the name, you can even if you forget, you can boldly say it is a factor 10A inhibitor. And direct thrombin inhibitor, dabigatran and fondaparinux, unfractioned heparin, and low molecular weight heparin. Okay, so these are all the drugs which are used commonly for producing anticoagulation. And of this vitamin K antagonist, this factor 10A and direct thrombin inhibitor, they can all be given by oral route. And of course, these two drugs also are given by oral route. And these other things, fondaparinux, unfractioned heparin, low molecular, they are all given parenterally. Now, 4 considerations that aim to guide the elective surgery cases. In cases where you have to electively take up a patient for surgery who are on anticoagulation, these 4 considerations you must keep in mind. One is determine the thromboembolic risk of the patient. So, for example, if a patient who had a previous DVT or a pulmonary embolism, or who is on atrial fibrillation, who has already had a left atrial thrombus, you must know whether by stopping the anticoagulant, there is a chance that the patient can again develop a thromboembolic phenomenon. The second is determine the procedural bleeding risk. So, intraoperatively, how much of blood loss will happen if you continue the antithrombotic agent to prevent the thrombus formation. Determine whether or not to interrupt the anticoagulation or antithrombotic therapy, and determine whether or not to bridge the anticoagulation. Bridging means stopping a long-acting drug and introducing a short-acting anticoagulation, which can be reversed easily. So that is what is called bridging. So you don't use a drug which has a very long duration of action. Instead, you stop the drug, but at the same time prevent a thrombus formation by introducing a short-acting drug which has got an antidote. In case of a severe bleeding, you can always correct that bleeding by giving the antidote of the drug. So these 4 things, if you remember the thrombotic risk, determine the procedural bleeding, determine whether you have to interrupt or continue, or whether you have to bridge. If these 4 questions are answered, then you can decide. Now, coming to the guidelines, for aspirin, they say nowadays you can continue, whether it is for regional or general anesthesia, you can continue with aspirin because the risk of bleeding is not that high. So earlier they were saying aspirin also should be stopped, but the general guidelines now is aspirin can be continued. Then all the antiplatelets like clopidogrel, the other drugs like ticagrelor, cangrelor, all these things you can stop 4 to 7 days. Warfarin you have to stop 3 to 5 days. And newer oral anticoagulation drugs preferably stop for 10 days. Low molecular weight stop for 12 hours before surgery and you can resume it 6 hours later. Heparin, because of short duration of action, if it is given intravenous, you can stop 4 hours before and start 2 hours later. So what is the difference between the mode of action of fondaparinux? What is fondaparinux? Any idea? Yeah. I think, did you mention about this drug, fondaparinux?
Yes, sir. Yes, sir.
What is?
And,
So it is a synthetic preparation, okay?
sir.
And it is a pentasaccharide. And the main difference between the factor 10A inhibitors and fondaparinux and low molecular weight heparin, which have a similar action, is they block the antithrombin, whereas the rivaroxaban and efaxiban, they come directly go and block the 10A, whereas they indirectly act by attaching themselves to antithrombin and then blocking the action. And that unfractioned heparin also has got a similar action. So this is the main difference between these two drugs. Okay? And this is the chart which will give you what are all the classes of anticoagulant agents, the examples of these drugs, like names and all the names are there, which she mentioned. So this is again a chart to know all the various drugs. And of course, these last drugs, the streptokinase, urokinase, which are all thrombolytic agents. Okay, so they are given to break a thrombosis, I mean a clot that has already been formed, commonly called as clot busters. So if a patient has already received these drugs for conservative management of a coronary thrombus or some other peripheral thrombosis, then you have to make sure that they don't bleed further. So these are also included in the discussion of antithrombotic agents or anticoagulants. And recommendations, of course, as I put it earlier in a very small form, it is given in a detailed form for warfarin 4 to 5 days, low molecular weight 12 hours before the onset, and you can start later, 6 hours later. Unfractioned heparin because of short action, 2 to 4 hours before that. And for regional anesthesia, it is mainly whether you can give an epidural or place a catheter or remove the catheter. These are the discussions you have to include in your answer. Whereas the other things, what all I told you, is mainly about the general guidelines for any surgical procedure. So remember these 3 points. One is what are the indications for anticoagulation, number 1. The second subdivision in your answer should be what are all the common drugs that are used. And the third thing is what are the considerations you have to do, the 4 considerations and I told you, and the guidelines when to stop, when to resume. And in case of risk of thrombosis, and you continue the drug and there is an intraoperative bleeding, how do you manage? So these are the points that you have expected to write in your answer for the question, anticoagulants and anesthesia. Okay, so that is a sort of in a nutshell what you have to write. Right? So I hope that visual slide will help you to remember what orally Vidhya described in detail about all the drugs. So by seeing the recording later, you will be able to easily recollect what is being just told orally. Okay, that is the purpose for which all these slides are made, so that you can, instead of noting down or taking a note, you have a ready-made notes here which you can go through later. Okay.
Yes.
Right. Any doubts or any questions, or shall we